I have the right. Okay, good afternoon, good afternoon, good afternoon, good afternoon. I hope everybody had a good lunch. We're going to get started here just momentarily. Just trying to bring up the folks from session 2 for novel imaging and biomarkers to guide RCC patient management. We have Dr. Sun, Dr. Morrissey, Dr. Waite, and Dr. Shah. Coming on up, please. And I'm pleased to introduce our 2 moderators. We have Stephanie Berg from Dana-Farber Cancer Center, as well as Katy Beckermann from Vanderbilt, who will be moderating this session. So thank you, Katy. Thank you, Stephanie. It's all yours.
Would you come in and sit down? Go ahead. Okay. All right, I hope everyone's bellies are nice and full and you're caffeinated appropriately, but we're excited to start this afternoon session off. I think this session is going to be just really enlightening. I think we're always excited about what are the next biomarkers, how are we going to think about diagnosing patients, how can we identify non-invasive methods of monitoring patients. And so I think you're going to hear a lot of great science and maybe what some of the next exciting biomarkers and novel imaging is going to be in kidney cancer. And so with that, I'm excited to welcome Dr. Sun to the stage, going to talk about PET imaging of HIF2 alpha in kidney cancer.
Thank you so much for your introduction. And actually, personally, I would like to thank KidneyCAN for such a wonderful opportunity. So actually, this is my first time to come here, so that's why I feel quite excited to share with you our work in progress on imaging HIF2 alpha for kidney cancer. And because we are only allowed to prepare 7 slides, so I didn't have my acknowledgement slide. So I just wanted to thank DoD Kidney Cancer Research Program to give us funding, and also the work I presented supported by Kidney Cancer Sport at Southwestern. So first, why HIF2 alpha? And this is because of hypoxia-inducible factors play a central role in the molecular pathways implicated in kidney cancer. And in normal cells, and HIF expression is regulated by VHL, and however, in over 80% of clear cell renal cell carcinoma, RCC, VHL is inactivated. So that's why the concentration of HIF2 alpha inside the cell is not regulated by a functional VHL. And so the targeting HIF2 alpha just have become a very promising therapeutic approach. And as you can just see from FDA's approval of Bazodifan, and all of you know that, and first approved in August 2021, and now just last December it has been expanded to metastatic RCC. Because not all kidney cancers express the HIF2 alpha, so that's why we think to develop a non-invasive imaging approach so that we can visualize HIF2 alpha for precision treatment with HIF2 alpha inhibitors could be quite important to the management of kidney cancer. So once we settled on the target, we need to, just from chemistry point of view, we need to have a structure lead so that we can develop a radio tracer or PET imaging probe to visualize HIF2 alpha. And let's take a look at the structure of the heterodimer of HIF2 alpha and HIF1 beta. As you can see in the heterodimer structure, in the green HIF2 alpha PASB domain, there's a cavity. So in heterodimer, the cavity is occupied by water. So this just raised interest, especially for chemists, to design allosteric HIF-2 alpha inhibitors. Here I'm showing you like 3 different HIF-2 alpha inhibitors. And actually our project got started roughly about 10 years ago. At that time, only PD2385, that structure was available to us. And when we take a look at the structure, as you can see, this cyanide on the benzoline and the fluorine on the benzoline, from my point of view, especially as a radiochemist, we can get them labeled by carbon 11 or F18. And to enable PET imaging of HIF-2 alpha, and I don't know if everybody know in this audience, because carbon 11 only have a 20 minutes half-life, F18 has 110 minutes half-life. So that's why we cannot just go with the traditional chemistry procedure to make those radio tracers. And so far, we are able to make both of the agents and perform the biological evaluation of both compounds. And because of time limits, I was able to just talk about, just focus on F18 labeled PD2385. And because, again, when you run radiochemistry, we have to run against the time. So that's why we designed multiple synthetic route to reach the compound we need, F18 labeled PD2385. And many synthetic rules just failed. And however, we have one synthetic rule that worked and also worked very good. So that's why we proceeded to use RCC tumor to perform our evaluation. As you can clearly see, F18 labeled PD2385 is able to differentiate the different level of HIF-2 expression. Sorry, to go back. Here. And also, the difference is a lot because of the vasculature density difference between the two models. And so that's why we move forward to perform a pre-IND study and get the dosimetry result and send the application to FDA and get IND approval. And once we got that, we also got IRB approval and started the first in-human trial with F18 labeled PD2385. And here I'm showing you the very first imaging result we have obtained. And once we got the result, actually we were a little disappointed because the renal mass here was not visualized. And later on we found out the mass is just simply because it is oncocytoma. So, and further, we further scanned 7 patients with renal mass. And among the 3 renal mass with MRI and pathology verified HIF-2 alpha expression, we're still not able to see the uptake. And then that's why we move on to run the kinetic modeling and found out, and actually by modeling, so the data influx of the agent F18 labeled PD2385 indeed has a higher uptake in the tumor. This is basically, from a proof of concept point of view, it shows the mechanism indeed work. And however, because of the uptake is low, we are not able to see the tumor clearly. So what's going on here? And then we perform the analysis. This is simply because of PD-2035 undergo first pass metabolism. And as you can see here, because of glucuronidation, glucuronic acid added to PD-2035, and this modification, I mean, talking about the chemical structure modification, dramatically changed the lipophilicity of all the agents. So that's why the compound cannot cross the cell membrane to reach the targets. And as you can clearly see from this figure, like the intact PD-2035 is very low as compared to the glucuronidated PD-2035. So that's why we moved on to the second generation of HIF-2α inhibitors, which is PD-2977. And as you can tell from the structure, and one of the fluorine atom moved away from hydroxy group to a distance carbon. So this modification is basically reduce the acidities of hydroxy group here to minimize glucuronidation. So that PD-2977 has enhanced the metabolic stability. And as you can see here, like, because of this movement, this compound will have 3 chiral centers. In terms of chemistry, that's gave us quite a bit of challenge. So in the past 1 year, like, we spent quite a bit of time to develop F18-labeled PD-2977. So right now, we're finally here. We got this compound, and we are poised to just perform preclinical evaluation and also pre-IND evaluation. And so that we can just assemble everything together to get IND for a clinical trial with this agent. And we hope PD-2977 with enhanced metabolic stability could help us to visualize HIF-2α positive tumor so that we can use it for precision treatment with HIF-2α inhibitors. Thank you.
With that, we have a few minutes for questions, and I think the boxes maybe are floating around. Do we have a question? Were you pointing? Sorry. Here you go. Oh, okay.
Great talk. With this second generation of your radio-labeled drug, have you tested whether you have impacted the binding, the amino acid in the PAS-B pocket that belzutifan binds to? Have you impacted that? Or, it's funny because I was speaking to Jim Brogolis this morning with regards to the drug resistance, some of the mutations patient acquired towards belzutifan, or at least in the PDX model that they showed, whether these compounds, your radio-labeled ones.
Well, that's a very good question, and that's a basic concept that we have to follow for our radio tracer development. And one thing, like I didn't say it, is for the labeling, no matter it's for carbon-11 labeling, F18 labeling, we didn't change the structure at all. So in other words, like the chemical and the biological property just maintain exactly the same as the substrate we used for the labeling. They maintain chemically identical.
So the second generation compound is also defined.
Right, but what I'm saying is that the modification has changed the property of the compound with regards to how it binds to the okay. That was my point. But
there's no modification of the compound. So it's F18 just replaced the F19 on the benzene ring. Carbon-11 is just the same, replace the carbon-12 on the benzene ring. So in other words, the chemically they are identical.
Thanks.
How transportable would that technology be?
Aren't you?
How transportable would that technology be? Obviously,
with F18, you need to synthesize very quickly because of the short half-life of F18, right? So you have to go through all the work to find the quick synthetic pathway. But let's say if it worked out, if you could identify high HIF2 expressing tumors which could have real clinical utility, how difficult would that be to transport that or export that to other cyclotron centers?
So that's actually the major issue, so we have to consider too. So we have to make the procedure reproducible, not just on the outside, but the other side. So that's why we have to develop the so-called SOP, standard operating procedures, so that they can be reproducible at the other side for multi-center trials. And actually, like for IND application, and what required to prepare a set of documents, which is called chemistry and manufacturing quality documents. So inside that documents, we provide the SOPs inside. So in other words, like any other sites, as long as you have cyclotrons, you should be able to follow the SOPs to reproduce the procedures for the aging productions.
All right, thank you very much.
Thank you.
Thank you, Dr. Morrissey. We are excited for your talk entitled Multiplexed Quantification of Urinary Biomarkers for a Non-Invasive Classification of Imaged Kidney Tumors.
Okay, this is financed by a kidney cancer, congressionally directed kidney cancer research fund, and I thank them for this opportunity. This is my disclosure slide, and that's because we are using plasmonic floor in the end to measure the biomarkers. And the background for this is a trial that we're just starting where we're gathering urine from patients that have an imaged kidney mass, and this is done prior to a procedure that they would have either surgical ablation or an ablative procedure from interventional radiology. And so this is sort of an amalgam of Dr. Singamaneni and myself, who are on the Danforth campus in material science, have developed plasmonic floor, and we're working with a urologic surgeon, an interventional radiologist, and then also a biostatistician for the project. But it is also a cross-Atlantic collaboration because we got antibodies for possible biomarkers of an oncocytoma and then another biomarker for clear cell from a group in Germany. And furthermore, we started a collaboration with a group in Nova University in Caparica, Portugal, that are doing proteomics on urine proteins of patients with imaged kidney masses. Now, the methods for this is basically we're collecting pre-procedure urine from patients that have a newly diagnosed imaged kidney mass. We're also collecting the urine after they've had their procedure because theoretically any biomarkers present pre-procedure would hopefully be gone post-procedure. And then we're also collecting urine from self-described normal individuals. Now, we're collecting basically 150 patients in each category, and for the self-described normal individuals, we're calling them basically 2 weeks after a patient is enrolled, and this is done in order to very closely age, sex, and ethnicity match the patient. And also, all patients enrolled in this have an imaged kidney mass 4 centimeters or under. Now, we're looking for biomarkers for clear cell tumors, which would be PLIN2, which is a lipid membrane protein, which is rich in clear cells because of the fact that they have a lot of lipid droplets. MXI2, which is supposed to be, at least from the German group, indicative of clear cell and papillary carcinomas. And then Vimentin 3, which is supposed to be indicative of oncocytoma. We're also evaluating kidney injury molecule 1, which is an injury marker for any renal kidney disease, but it is also elevated in patients with clear cell and papillary carcinomas. The thing about plasmonic floor is illustrated here. We're basically taking a gold nanorod, which we synthesize with precise dimensions, and then encapsulate it with a silane polymer and decorate it with bovine serum albumin that has a fluorophore. And the reason for the silane encapsulation is that it's only about 2 nanometers thick, and it puts the phore at a level where the gold nanorod greatly amplifies the fluorescent signal. And we can achieve at least 6,000-fold increase in any fluorescent signal with suitably synthesized gold nanorods. And we have developed several multiplexed assays here for various cytokines so that we can measure attomole or femtomole per mil levels of a variety of biomarkers, and then we're hoping to put this together for the kidney cancer project. And achieving this goal, we hope to have developed a multiplexed assay so that post-imaging, the physicians might be able to get a better idea of what type of tumor that they're dealing with, especially since many imaged kidney masses, on about the order of 30%, may be oncocytomas and not necessarily having to have some type of surgical or ablative procedure performed, only to find that it might be a benign tumor. And I thank you for your attention. Now, I might also say that Srikanth is the PI on the project, but he is at an NIH study section, so I'm filling in.
Thank you. Thanks. I'll start off. There's a question that's come in from the poll here, and it says, can these biomarkers be tested post-nephrectomy to evaluate whether a patient might need adjuvant therapy?
They could also be evaluated post-nephrectomy, maybe to see that there's no tumor recurrence. And it might also, if there's not a surgical or ablative procedure, they might also be able to evaluate the effectiveness of systemic treatment like immunotherapy. And if anybody has any other questions, we have poster 31, I believe, so you can ask later.
And I was wondering, you mentioned why these specific markers were chosen to look in your multiplex assay, but I wonder how you happened upon these particular 5 versus 1, or choosing 10, or if there's limitations in the assay itself.
Okay. Quite a while ago, our lab had looked at aquaporin 1 and plin 2 as biomarkers for kidney cancer, mainly for clear cell and papillary subtypes. We're also going to be measuring aquaporin 1, but we're also doing spotting urine dipsticks with the urine of the patient to make sure or to look for any hematuria that the patient may have, because that could complicate aquaporin 1, but we're settling on PLIN 2 because of the lipid content of the clear cell and to some extent the lipid content of papillary. And then the MXI2 and Vimentin 3 were markers that the group in Cologne, Germany was using and had said that they are indicative of clear cell papillary for MXI2, and Vimentin 3 was an oncocytoma. But then as a backup, we're also working with a group in Nova University in Caparica, Portugal, which has been publishing information about proteins in different kidney tumors, and they're now starting to look at the urine of those patients. So we could add additional biomarkers or subtract a biomarker if we don't have correlations with what the pathologist says. And well, basically what the pathologist says. The first 2 years of the study, we're doing this knowing what the outcome of the tumor was. The third year, our lab will be blinded to the path report, and then we're going to have another tech scramble the first 2 years worth of urine, and we wouldn't know what the outcome was until we unmask things.
Can I ask a question?
Sure.
Is it trying to distinguish just between cancer or no, or are there efforts to determine between indolent or slow, minimally aggressive tumors and more aggressive tumors based on these?
Okay. Well, I'm not a physician, but my understanding is that this could be used for surveillance for small masses that have biomarker characteristics of like an oncocytoma. Hopefully with information we're going to get from the Portugal group, we might be able to find something that would be indicative of an indolent tumor. But those are questions that we have and hopefully can answer. Okay.
Great talk. I just wanted to find out, do you see a similar pattern in blood? I know the whole purpose is to find a non-invasive liquid biomarker, but if I was to look into the plasma, would we find a similar pattern to be able to see before nephrectomy, after nephrectomy, or be able to predict the success of immunotherapy in adjuvant setting?
Okay, so you're basically asking if we look in the plasma,
Yes.
might we see the same things?
Yes, do they correlate, the urine and plasma?
Is data available that kidney injury molecule 1 is something that you could follow in the serum or the plasma? We could eventually look in the plasma of the patients prior to and after their procedure, but we would have to add that to the existing IRB.
So that is something exploratory that your group is doing?
Pardon me?
So that is something that your group is pursuing. We do not have an answer yet.
We don't have an answer yet, but there is literature on kidney injury molecule 1.
Thank you.
Okay. Okay.
Okay, up next, thank you very much, Dr. Morrissey. Up next, we have Dr. Christopher Wright from Cleveland Clinic discussing multimodal AI-based renal cancer patient care.
Thank you very much. I am honored to be here. I grew up in rural Utah, which I always thought was a disadvantage for things like this, but after hearing the talk this morning, maybe living in a rural place is an advantage. really happy to be here with such a distinguished group. So I'm a urologic oncologist, so I see a lot of patients, and when they sit in front of me, they have questions similar to the emotion that we heard Brian in his introduction today, like what is happening to me when he showed the picture of his kids and wondered if he would see them graduate. That was very telling, and this is what the patients want to know. You know, what's going to happen? Will this kill me? What is my best treatment option? Are family members at risk? These are the sorts of questions that should always be before us as we make our inquiries into kidney cancer research. And similar to what Dr. Morrissey just presented, we're also interested in a problem we see in surgery is that a lot of times we take a patient to surgery thinking they have a potentially life-threatening tumor, and we find out that it is either a benign tumor or an indolent tumor, a tumor that would very unlikely affect their life expectancy. And it's estimated nearly $200 million worth of surgery and healthcare costs are expended on these patients with no real benefit from a survival standpoint. And so we're very interested in trying to understand how we can distinguish this. And I want to start by saying this is kind of a model of clinical research that we take data from a patient and its various sources, demographics, x-rays, microbiome, genomics, pathology, et cetera. We put this into a place we call patient data. It's usually the EMR now, but to get to the EMR, there's usually some level of interpretation. There's some level of error in that interpretation or variability at a minimum. We usually put it in as analog data points, and then we usually send medical students and residents and undergrads back into the EMR, and they pull out data about these patients, and they usually pull it into a database, and they digitize these analog data points. And that takes time and capital, and then there's data loss. And then we analyze the data, and we usually put them into groups of patients. And with this method, we're able to often find some groups that will do fairly well and some groups that will do fairly poorly. But it's also the average, and the average maybe doesn't tell us what's going on with most patients. And so here's an average response. This is to I think this is data from a TKI. It's meant to be representative. In kidney cancer, it shows the average reduction was about a 5% reduction in tumor size. But you can see the average is not that representative of a lot of the patients. So, you know, this is the average here, but the tumor grew threefold while they were on treatment, and some it nearly went clearly away. And the average represents not the majority of patients. And we know that most of our clinical data, our clinical trials, our retrospective research still only represents a fraction, maybe 1 to 5% of all the patients that have these tumors. And therefore, we are working in a setting of not knowing what's going on with the majority of our patients. And we see, for example, when we develop nomograms, over time those nomograms lose their predictive ability. They don't do as well 20 years later because the etiology and the populations are changing, and there are so many other things that can affect this. And so when we're thinking about multimodal AI-based renal patient care, renal cell patient care, we're thinking of taking the data straight from the patient and bypassing those other places that take time and effort and interpreter variability and going straight to analyzing the data. And so this is a little scary. You just stick all the data into the algorithm. The algorithm spits out what it's learned about the patients. And then we try to understand and see how that does compared to expert opinion. So I've often wondered this: where is the predictive and the prognostic data for our patients? We've seen a lot of people are doing some work in the DNA and RNA world. There's certainly proteomics. We're doing some small cell stuff these days, but also there's a lot of predictive. Once you actually get the tissue, that tissue comes together to form a tumor that we can image with cross-sectional imaging. And then, of course, there are details about the patient that it's in that also affect these outcomes. And sometimes we get siloed and we're just thinking about our little spot on this pathway, and this is not even meant to be completely comprehensive. But where we are thinking is the, despite being able to do gene expression profiles, a ruler in kidney cancer is still almost one of the most predictive, the most effective predictive tools we have is just measuring the size of the tumor. So we're kind of focusing most of our efforts when we're getting closer to the phenotype in the tissue and the way the tumor images on a cross-sectional imaging. And then as I'll show you some bit also about the person that the tumor is in. So this is a DoD grant. We just got it this last fall, so we're not as far along as some of the other groups. These are the aims, is can we use artificial intelligence and computer vision to help us interpret medical images, specifically CT and pathologic images, H&E stained pathologic images, along with demographic data to be better at predicting which are the potentially aggressive tumors and also other important perioperative characteristics. And then the second aim is can we use a fully automated tool on CT imaging and knowing baseline creatinine or baseline kidney function to estimate postoperative kidney function if we were to do a partial or a radical nephrectomy. Where we are currently is we are trying to create this cohort to train the models on. We had initially intended to have about 1,000 to 1,500 patients, but we've been working, now that large language models are so available, we've been using a large language model to query our EMR. And with some very intelligent computer scientists that are working with me, and some sort of going back and forth through pathology reports, radiology reports, I think we're going to actually be able to build this out to a much larger cohort. For example, with our pathology reports, we now have written a code using large language models, sort of limiting the choices, and in 1 week we queried 10,000 pathology reports and had a pretty high level in the subset where we had already gone back into the EMR with our medical students and residents. We got about a 97 to 98% accuracy to what the medical students and residents did on pulling the data out from the pathology reports. We also are getting together the cohorts. We have about 3,000 patients that have H&E stains, as well as a similar number that will have corresponding CT scans. So we're in the midst of this. We have a smaller subset, about 300, that we're hoping to have gene expression on. And then I would just want to comment, I feel that as a clinician, there's a lot of information in that CT scan that we don't have a way to quantify, and this is just one bit that has come out. This is unpublished. We just recently submitted this for publication, but there are many studies that show that you can show a CT scan or a chest x-ray, and you can train it to very accurately predict a patient's age, gender, and ethnicity, even when you don't show the reproductive organs, right? You can show 1/9 of a chest x-ray, and the AI algorithm is very good at predicting what the age, the gender, the ethnicity. So we thought, well, let's create a model where we train the model to predict age, but what will be really interesting is if there's a discrepancy in the chronologic age, the real age of the patient, and what the AI thinks the patient is. And if the AI thinks you're younger, will you do better than if the AI thinks you're your actual age? And so this is just 2 outcomes that we looked at here that showed indeed that was the case. This was kidney cancer patients who underwent surgery. This AI age discrepancy, if the computer thought you were younger than you actually were, you actually significantly were more likely to get out of the hospital at a faster time period. And that was interestingly independent, and your real age actually had no role. But if the AI thought you were younger than you were or thought you were older than you were, it had a role. But also even on survival, AI age was a significant predictor, whereas your true age wasn't an independent predictor. So I think there is data contained in these images that we haven't had a way to really grasp and understand yet. And I'm really excited to see what comes out of this as we push further forward. So in conclusion, we've done a lot of work already that if you can segment the image, if you can put in a CT scan, outline the kidney, outline the tumor, we can get a very reliable prediction of postoperative kidney function. We've done this by hand, but now we're doing it with automatic segmentation, and the results are looking really promising. And as I just showed here, I think we're going to discover new features our next step is to compare this AIH to ECOG. I think it's going to be ECOG, and it's going to be available. Almost every one of our patients is going to have a CT scan. And so if we can have that's part of our report, your AIH, for example, or the AIH discrepancy, it might offer us valuable information that we can eventually get to the point where we can really personalize healthcare using some of these non-invasive methods that are already at our fingertips. Thank you.
Questions? Kyle?
Could easily be evaluated. My question is, how would you know how accurate it was? Because LLMs are known to hallucinate, and if you don't have a robust, large, well-validated cohort already existing, it could be, it's easy to run it. I think it's harder to evaluate it.
Yeah, no, because we had already had medical students go through the same charts. So we had several thousand that we had medical students and fellows that had gone through them in the past. In fact, we had a really, one fellow had gone through 3,000 charts and had just barely completed his 3,000 chart evaluation with all of the pathology. And then we ran this in a week. And it was 97% accurate compared to his. And interestingly, so now we have another student that we're sending back to look at the discrepancies. And so far, 70% of the time, our model was right and the fellow was wrong. When we go back, because the resident that's going back to the charts doesn't know which one was right. Just knows there was discrepancy and comes back and makes the best guess. And so far, 70% of the time, the model got it right. So we've done this iteratively. We've done it multiple times. The first time we did it, we did not get this. We've been doing it for about 6 months, tweaking the model every time to try to get it better and better. But the most recent iteration, that's what we found.
Thank you.
Yeah.
Michelle?
So I'm just curious, you said you image or you scan out the background
Oh.
almost. All right. Sorry. My bad. My kids are better athletes. So my question is, you said you image the area of the kidney, the non-neoplastic kidney, as well as the kidney mass itself, and I'm wondering if you're getting different results based on whether the patient has background kidney disease. We often evaluate the non-neoplastic. Some have glomerulosclerosis, some don't. You know, if it's a healthy kidney or a non-healthy kidney, really is the question. Is that changing your results?
I guess it depends on what outcome you're talking about. It may. If you're looking at we haven't looked specifically at cancer, whether it alters our ability to predict whether it's cancer or no, or whether it's kind of we use this combined endpoint, potentially aggressive, which is, you know, grade 3 or 4 in renal cell carcinoma, or stage 3 or higher. We haven't looked specifically at that to see, but it will likely affect our renal function predictions, I think, because, but the renal function is based on the parenchymal volume. So many things we've tried to do is first replicate pre-existing clinical systems and then compare those. So like you guys all may know about things like nephrometry score. So we tried to replicate nephrometry score first and compare it to expert nephrometry score. We've tried to do these tumor volume, or sorry, the parenchymal volume and replicate that, and that's doing pretty good. But the next step, which makes us a little bit more nervous, is just directly predict the outcome without kind of in that model that I showed you, just go all the data straight to the outcome. That probably will do better, but then we get a little bit nervous because we don't know how it's making the decision. And so that's why we've kind of prioritized first trying to replicate clinical models that we already know how they work and trying to beat them. And we usually can because we're not limited by simplicity. Nephrometry, for example, is limited by simplicity because you try to make it easy so a clinician can do it really quickly at the point of care. But we can weight the variables, we can make them continuous rather than categorical. So it will be interesting to see. There could be other things that will affect that.
Over here.
Yeah.
Hi, thank you for the talk. It's very interesting to see how LLMs can be used, you know, to predict function and prognosis and so on. My question is, given all of the parameters that go into the model, which parameters drive the the prediction? Have you done that kind of analysis?
You know, we're not complete yet, but when we have done it, so we've done a lot more work in the CT scan evaluation, and the size is a hugely important predictor. That's why I kind of started with the ruler is is one of the best tools right now we still have for predicting how a patient's going to do with renal cell carcinoma. It takes a lot to beat the ruler. I think we can beat size alone by adding in some of these other things, but size is one of the biggest factors. We have not done the pathology. I think the pathology is going to help us quite a bit. That's the piece that we are just getting to the point now. We're trying to get all this clinical data together so we can match it up with the H&E slides. I think that's going to add an additional bump. Now, a lot of people will say, well, you don't get the pathology till you take the tumor out, and that's true, although we can do biopsy, and I think it will probably lead us to a point where we'll be able to get a lot of information from the scan, most of the information we need from the scan, and then on a subset, we won't have enough information, and then a biopsy might be extremely helpful, and I think it's going to help us a lot. I think, at least so far, gene expression is the third category where we're going to have a small subset. We'll see if that adds a lot more, but I'm not convinced it's going to add a whole lot more than those other two, but we'll have to see.
Just following up on that one, supposing you take, let's say, smaller size, on the small end, have you done that kind of subgroup analysis to see at that end which parameters play a more important role?
If we limit it to like the 4 centimeter or smaller, and we haven't done that yet, but it will be something interesting to do because that's where the most diagnostic dilemma comes from, right? That's where we're like, well, should we take this out or not? And that's an important area.
Thank you.
I think for subgrouping, I mean, clearly the larger ones, especially if they're bad subtypes, are going to obviously do worse, but patients that are found because they're symptomatic and have a large kidney mass versus someone who had diverticulosis in a CT scan and you found their mass is going to be much smaller but might have been on a spectrum to grow had you not. So subgrouping the cases into those that are found incidentally versus those that are found symptomatically but same biology, just time point when it's found might also show you something different, which could be interesting.
Seeing if there is tumor or not, if you're just looking at CT scans from patients who are still not detected with kidney cancer. Can you predict if there is something or not based on the scans?
So to compare a completely normal kidney to, I'm sure it can. We haven't focused on that, but I'm sure, you know, for example, one of the questioners asked about hallucinations. You know, we do have 2 kidneys, right? So it's not very common at all that the current algorithm we're using would hallucinate a tumor on the other side. So it's pretty good at finding which side the tumor's on. And so we have not trained it, or we have not put in people that don't have any tumors. It's something that we want to do. We're probably going to do it with kidney donors because we have a lot of access to those. To make sure it doesn't feel like it has to say there's a tumor somewhere, because that's how we've shown the model so far. But yeah, you could conceivably, this version of technology could be easily seen as something that can do a first pass scan on anybody and alert a radiologist, say, look, I know they came in for appendicitis, but maybe you should check out this thing on the kidney.
You could also probably try in a patient population of like HLRCC patients who haven't developed kidney cancer and are under surveillance or other familial kidney disorders, and some, you know, that might be an interesting population to look at as well, because they may or may not develop cancer, you know, in the kidney later.
Thank you. And our last speaker is Valisha Shah from Dana-Farber. She's going to discuss the topic shared heritability between RCC and hematopoietic-related phenotypes.
This is for okay. Hi everyone. So I'll be presenting our work with shared heritability between renal cell carcinoma and hematopoietic-related phenotypes. A lot of what was covered in the morning today So I'll go over the introduction quickly. Clonal hematopoiesis is caused by mutation in the hematopoietic stem cell. If the mutation is capable in providing selective advantage to that particular mutated cell, it could lead to clonal expansion, and that is termed as clonal hematopoiesis. Clonal hematopoiesis is occur due to errors in DNA correction mechanism, which could lead to cytosine deamination, double-stranded breaks, or large chromosomal events such as insertions, deletions. And if this particular cell gets a selective advantage, they could be mutated, and it could lead to clonal hematopoiesis. And so our objective is to see if there is any potential genetic correlation between clonal hematopoiesis and renal cell carcinoma. Why do we think there could be a potential link between clonal hematopoiesis and RCC? Is because in past there were studies which showed a correlation between cardiovascular events and clonal hematopoiesis. It was seen that in general population, patients with clonal hematopoiesis showed increased mortality rate by 40%, which was not explained by hematologic cancer, but rather clonal hematopoiesis was related to increased cardiovascular events, such as coronary artery diseases, ischemic stroke, etc. And then the next link was between cardiovascular events and renal cell carcinoma. In a study done by Dr. Maxine's son before, she had observed that there is an increased predisposition of cardiovascular events in cancer, and it was notable in renal cell carcinoma. So carriers of mosaic chromosomal alterations in the cancer population had a higher risk to cardiovascular events. And so now we want to study if there is any genetic correlation between clonal hematopoiesis and renal cell carcinoma. This could help us in understanding if there are common genetic pathways, molecular mechanisms that drives both the events together, and probably lead us to better therapeutic options for patients with both cardiovascular events and renal cell carcinoma. To briefly go over the 4 different types of clonal hematopoietic phenotypes, the first 2 are loss of Y and loss of X chromosome. They are namely the absence of X and Y chromosome in that particular population. The next is autosomal mosaic chromosomal alterations. These are large structural events that happen in the autosomal chromosomes. And then finally, clonal hematopoiesis of indeterminate potential. These populations have cancer-driving mutations, but they're not necessarily malignant, and thus termed as of indeterminate potential. And to assess the genetic correlation between clonal hematopoiesis and RCC, we have used the LDSC tool. For the presentation today, I'll be focusing only on the loss of Y phenotype. The LDSC tool leverages a phenomenon called linkage disequilibrium. So this essentially provides an LD score to each SNP. And it means that if the SNPs are pretty close to each other on the allele, there is a very less chance of recombination occurring. And so this can help us understand if the genetic variation is correlated to the phenotypical variation. To go on to the data, we had 2 traits here. First was the RCC from Mark Perdue. It was a multi-ancestry study, but we would just be focusing on European ancestry. And we would also be focusing just on clear cell histology. The loss of Y data was obtained from Thompson et al. The loss of Y was determined using 156 different autosomal mutations. And this was the population size and the total number of SNPs with this data. So going to the results finally, this LDSC tool first starts with analyzing the SNPs from both the traits that we have. The second thing it does is looks at the heritability score. Heritability score is basically a variation, like the proportion of variation that could be explained by the genetic factors. It is on a scale of 0 to 1. So I've just tried to show an example that the closer it is to 1, it is a generic example. So the closer it is to 1, the more are the genetic factors being able to explain the phenotypical traits. And so with the RCC and loss of Y, we see that the heritability score with our data was pretty close to 0. And that heritability score is eventually used to calculate the genetic covariance and correlation. The correlation is an estimate, basically saying that if we have RCC and loss of Y, and we look at those two phenotypical traits, are the genetic variations being able to, how are they overlapping with each other? And if it is 1, it means there's a complete overlap, and if it's 0, it means that there's no overlap between both the traits. Covariance, it's an estimate of how the two traits change together. And also from here, we can see that these values that we had for correlation and covariance was also closer to 0, showing that the relationship between these two traits, loss of Y and RCC, was insignificant. And finally, to conclude, the lack of genetic link implies that if there were pathways that were perpetuating cardiovascular risk in patients with RCC, they were different from those associated with loss of Y. And in future, we would like to test the other clonal hematopoietic phenotypes, as I mentioned before, and explore a newer technique than LTSE. And lastly, to conclude, I would like to thank my mentors, Dr. Maxine Sun, Dr. Tony Chouery, Dr. Sasha Gusev, and Dr. David Brown, also the whole of the WCRM team. They have always been there through the tough times. Mark Perdue and Thompson are all to provide us with the data, DoD funding mechanism for funding this project, and finally, KCRS committee to allowing me for presenting today. Thank you.
Questions? Dr. Simon?
For this presentation, yes, but with the whole project, we would like to do it with the rest of the phenotypes as well.
Maybe I'll get better as the meeting goes on. I'm sorry, I was focusing on catching the ball. What did you say?
So for this presentation, we just started working on it recently, so we've just started with the loss of Y. But as a whole, we would like to do all the rest of the phenotypical traits as well, mosaic chromosomal alterations, chip, everything.
Is there a reason you started with loss of Y? Was that particularly promising in your opinion?
No, it was just the data was readily available than the rest of it. Okay. We're still trying to get the data for the other phenotypical traits.
Okay, great, thank you.
So
here you go.
I think your look at LOY is in the germline level. Have you looked at the tumors?
Sorry, I did not. Can you repeat that?
Well, I think the data you presented is at the germline level. Because
I'm not sure. I don't think.
Yeah, this is what I was going to ask you. The part that was a little bit, are you looking only at the hematopoietic cells were they in circulation, or were they tumor associated? What was the mutational status of the tumor itself? There's a lot of complicated genetic interaction occurring over here.
So with the data here, they were related to cancer, and they were also the clonal hematopoietic ones which had the loss of Y in them.
The tumor has no relation to the sex-linked genes in terms of whatever, KDM5C, 6A, none of those are impacted in the tumor itself. Would you know that?
No, I'm sorry, I don't know that.
Yeah, so I just want to emphasize, because I think the data set you used is at the genetic level, it's at the germline level. The GWAS data you use,
yes.
Yeah, that's germline level, but it's not a tumor level.
Yeah.
But there is a separate paper published a year ago in Cell. In kidney cancer, the LOY is like 50%.
Okay.
Yeah.
Yeah.
Anyone else?
Thanks, everyone. I think that concludes our session. And next up is session 3, State of the Science.